So far we have seen about angina pectoris. We have seen that angina pectoris is because of the problem that is demand supply gap is there, and therefore there is angina, and according to the situation we have got various classes, stable, unstable, etc., and accordingly even sign symptoms can vary, uh, and the tests are done, various tests are done to verify, and accordingly treatments are there. We have seen what are the major treatments, that is calcium channel blockers, nitrates, beta blocker. These are important treatments we have seen, or rather first line treatments. Now let us go for the next problem, that is again it is one of the acute coronary syndrome. There are two acute coronary syndrome. It can be angina, acute angina, it can be myocardial infarction. The difference is many times the signs are similar, overlapping, but in angina at least there is a previous episode of angina, and during that it is known that the person is having the chances because of narrowing of the artery. Here myocardial infarction is many times it is all of a sudden, and this is the rupture of atherosclerotic plaque, and that rupture resulting into occlusion of major artery and major coronary artery, major branch of coronary artery rather I'll say, and this because of sudden severe occlusion, the supply stops to that particular area, and because of that the area that becomes necrotized, again chest pain, everything will be similar, and that will result into damage to that area, that will affect pumping, and sometime it can even cause stoppage of heart. That can be very dangerous situation. So what is myocardial infarction? Is an ischemic necrosis of myocardium. It is caused by occlusion of coronary artery and prolonged myocardial this one. It is an extreme consequence of acute coronary syndrome, as I told you, and the spectrum of clinical state, they are caused by instability of coronary artery lumen, because plaque is there, and plaque can result into breakage, so it is not stable plaque, and then this result into thrombosis and everything that causes occlusion of artery. There are approximately 50,000 cases annually in Ukraine, and everywhere it is increasing. In India also they are increasing. Mortality rate is very high, up to 50%, up to 60% of death they occur before admission to the hospital, and 1.5 million case they are there in US, annually 60 cases per 10,000. So at in all countries there is a situation, and these are increasing everywhere. So that is a very dangerous, very difficult one. Now what are the diagnostic criteria? How we can say that patient has got myocardial infarction? So there are various important tools, because we don't have much time, but by that time whatsoever possible has to be done. So first one is typical rise and gradual fall of troponin. This is troponin, you must be knowing, it is a protein which is present in the muscle, and normally it is not available in high amount in the blood, but because it is inside the muscle, but whenever it is also particularly called as a troponin T. So this troponin T particularly is specific in the cardiac muscles. So whenever there is a ischemic injury, because of necrosis, the troponin T will be released in the blood, and its level will increase manifold, and this is more rapid and rise in rapid rise and fall is there. So this type of things are known as a biochemical markers, because they are present in the body, they are the chemicals, they can be checked, their level can be measured, they are analyzed, and their level when change, that indicates some of the disease. So there are many such biochemical markers which are present. They are very, very important diagnostic tools. So here these are various biochemical markers. One is troponin T, then the CKMB, that is creatinine kinase MB. There are variety of creatinine kinase which are present. Those who are studying, or if you are going for pathology book, please refer Hirschman and any other pathological book. You will find very good graph of changes of the various biochemical marker. What are various this you can take as a homework, you can post it on our WhatsApp group. Okay, so what are the changes which are taking place during myocardial infarction? Okay, you will get very good graph of this from Harshmoon. So this is troponin T is one there, that in CKMB is there, one more enzyme is there that is known as a lactose dehydrogenase. Then third one is there, this R, that is SGOT, SGPT. They are lesser important, but they are also there. So these are various biomarkers, these are biochemical marker which are assessed. Then second thing is various ischemic symptoms, that is very typical changes, that is pain in the arm, pain in the shoulder, as we have seen in the angina. Then severe or what we can say, heaviness in chest, burning like sensation. All these things we have seen in acute angina earlier. So similar, this all signs will be there because of the ischemic injury. Then second, there will be development of pathological Q waves on the ECGs. ECG changes are there, either ST segment elevation or ST segment depression. So these are called as a, and they accordingly we classify it as a STMI, that is ST segment or ST elevation, STEMI, that is ST elevation myocardial infarction, or NSTMI. So that means that there is a no ST elevation. These were two cases were found that these are there, and accordingly it can be there. Then coronary and artery intervention can be done, that is called as a coronary artery angiography first. Actually that helps in the diagnosis. Angiography is the procedure wherein the dye is inserted, some dye is put into, and it is checked that where the dye is flowing, and it is marked, it is observed from outside, and this color, this dye is wherever it is present, that means that area is open. But if it is obstructed, suppose earlier it is mixed well in the blood, and whenever it is going, then all of a sudden you can see that the path has narrowed. Okay, so this narrowed path can be immediately seen, it can be visualized, and accordingly it will give indication that yes, there is a blockage, and how much is the blockage. So this is what called as a coronary artery interventions. Then pathological findings of an acute myocardial infarctions that can be checked. What are various reasons behind it? What are the most patient who are having myocardial infarction, they are having coronary artery atherosclerosis. The thrombus formation occurs most often at the site of atherosclerotic lesion, and thus it obstructs the blood flows to the myocardial tissue, or which is subsequent. Plaque rupture is believed to be triggering mechanism for the development of thrombus in most of the patients, and when the plaques rupture, thrombus is formed at the site that can be occluded blood flow, and thus resulting into an MI. There are two types of plaques which are there. Some plaques are vulnerable plaques, some are the stable plaque. Stable plaques where the liquid core is quite deep inside, while if the liquid core or lipid core is more, and the lumen, you can see the thickness changes. Here thickness of that intima layer of artery is less, and here the maximum is a lipid core, where this can generate pressure and it can cause bursting of this, while here this is a stable plaque, second one is which is below, and the lipid core is smaller one, and there is a growth, although it has reduced lumen too much, but it can cause more rupture, while it has got lesser chances of rupture. So these are various components of this atherosclerotic place. So these are T lymphocytes, then macrophages which are forming foam cells, then there are activated intimal these cells are there, mucosal cells are there, normal medial smooth muscle cells are there. So these are various smooth muscle cells are there which are activated or normal type of, and thus they all are playing important role in that. So irreversible damage to the myocardium can begin at as early as 20 to 40 minutes after interruption of blood flow. Uh, the dynamic process of infarction may not be completed for several hours. The necrosis of tissue appear to occur in subsequent in the sequential fashion. Cellular death occurs first in the subendocardial layer, then it spreads like a wavefront throughout the thickness of the wall of the heart. The shorter the time between the coronary occlusion and coronary reperfusion, the greater is the amount of myocardial. Good afternoon. Just okay. Thank you. The shorter the time between coronary occlusion, thank you, coronary reperfusion, the greater amount of the myocardial tissue that can be salvaged. So this is very important. Again, suppose somebody is having sign of myocardial infarction, as fast the treatment can be done, the more chances of its recovery and better prognosis. We have used the word prognosis earlier also. Prognosis means cure or getting well, getting normal. So if the in heart attack cases, if the patient is immediately taken care of, or if the time between starting treatment and the first episode, if it is less in between, then the chances of prognosis are better. And as it progresses, then prognosis can go on decreasing, then mortality, morbidities can be there. So these are actually the problems which are very, very important, and therefore the patient has to be as far as very fast should be carried to there. The time is there, that is the myocardial damage can occur and it has to be done very fast as possible. Then next thing happens, these are called as cellular changes. They are associated with myocardial infarction. So what happened into that? There is a development of infarct extension. That is, there is a new myocardial necrosis. Then there is a infarct, and whatsoever occlusion is there, or the area which has received less blood supply, that is called as an infarct. Okay. So there is an infarct expansion, that is disproportionate thinning and dilatation of the infarct zone. So this infarct zone will be increasing. Then ventricular remodeling that takes place after that, that is disproportionate thinning and the dilatation of the ventricle. This is usually the reason behind heart failure. If you go back earlier, we have studied about it, that because of the injury there is a repair procedure, repair mechanism starts, and while repair mechanism, instead of normal parenchymal heart cells or heart muscle cells, the fibrous tissue is there, and that can cause increase in the size, but it does not actually have the functional aspects. So this is what the functional aspects are there, they are important. Then myocardial infarction most often result into damage to the left ventricle, because you can imagine it has to pump it for the whole body. So left ventricle has got more thickness, more work, more pressure, and therefore it can be very dangerous one. It leads to alteration in left ventricular function. Infarction can also occur in right ventricle, or it can occur in both ventricles simultaneously. It will depend, but maximum it occurs in the left ventricular, because left ventricle contractions are more, wear and tear is more, friction is more, forceful contractions are more. So therefore in left ventricle they are more prone. Then next is, we can classify it in two ways, on the basis of anatomy and clinical diagnostic information. Clinically we call it, we can call it as a transmural and subendocardial. We shall see one by one. And diagnostic we have classified already, I told you, STEMI and non-STEMI, where the ECG shows elevation of ST segment, or there is a no elevation, or rather there can be depression of ST segment. So this we call it as a non-ST elevation. So there are two basic ways of classification. How we classify them, it can be basis on the location of also. It can be located in the anterior, septal, lateral, posterior or inferior wall of that heart. So these are various important arteries. This is called as a left coronary descending artery, and this is right coronary artery, and there is one more that is which is circumflex, which is that is called as circumventricle. So these are various arteries are there, and accordingly it can be anterior, it can be septal, it can be lateral, it can be posterior, or it can be inferior walls of the ventricle. So at various places it can be occurring. We can have diagram of coronary arteries which are arising from aorta and encircling that. So these are various arteries. This is left main coronary artery. From that there is a branch that is, I told you, circumflex coronary artery. Then most important is left anterior descending coronary artery, or it is very commonly called as a LAD, left anterior descending coronary artery. This LAD is most prone because it is supplying blood to the left ventricular of the heart, and it is reaching to the apex of the heart. This is the most vulnerable. This is, now you can imagine on the heart, we shall see one by one. We will see first. Then there is a posterior descending coronary artery. This is at the back side. This is the artery which is going, if this you can see the red one. So this will be going towards that, that is known as a descending one. And there is another one is the circumflex coronary artery. So these are various arteries which are there, and accordingly depending on the block, suppose block is here, then it will cause the damage to this much area. If the block is at the end, okay, as you go away from the block, accordingly block it will be there. So if it is more and more closer, we will call it as a more and more proximal to the main coronary artery. So if it is more left main coronary artery, then it may cause a bigger area, and that can even lead to death of the person, because that is very big area. It will be damaging, and it will not allow heart to pump blood from the left ventricle. So accordingly we can have classifications of various locational changes we can have, or on the basis of that we can have the various classes of myocardial infarction. First one is there, that is called as a anteroseptal wall, that is anterior and the septum and wall. So where it is which coronary artery, it is a left anterior descending artery is there, that where there is a block, or there is atherosclerotic plaque is there. It supplies blood to the anterior wall of the left ventricular and also intraventricular septum, and thus this ventricular conducting tissue. ECG will show ST elevation and Q waves and ST elevation. These are major one, V1 and V4. Again it will be there. It is what we have to do here is potential or significant hemodynamic compromise will be there. It will cause congestive cardiac failure, it will cause pulmonary edema, it will cause cardiogenic shock, and it can cause intraventricular conduction disturbances. So these are various implications are there, and if they are severe, then yes, definitely it will lead to death of the patient. Then lateral wall, it is because of the left circumflex coronary artery, it supplies blood to the left lateral and left posterior walls and to the SA node in 45% of the people and AV node in the 10% of the people. Then what changes you will able to find, will find that ST segment elevation. Then if you will see another version of ECGs, then you will find that 1A, VL, VS and V6 are there. Whenever ST segment elevation is there, along with that Q wave is also disturbed, so always it is there. Then evaluation of posterior wall involvement has to be checked. Some hemodynamic changes it can make, and it will cause dysarrhythmias because of the SA or AV node dysfunction. So dysarrhythmias means it can be either increased, or it can be tachyarrhythmias, or it can be bradyarrhythmias. Then posterior wall, it is because of the left circumflex one, there is a block or there is a problem with that. It because it supplies blood to the left lateral and the left posterior walls, and in some 45% of the people it supplies blood to SA node, and around 10% it supplies to AV node. So here also you can find either ST segment depression or ST segment elevation. So this is a bit complicated to diagnose. It can cause elevation for lateral wall involvement. There is hemodynamic changes. There can be dysrhythmias, which is caused by SA node and SC node. So posterior wall and lateral wall, they are similar. Then next is inferior wall. The artery which is, or the branch supplying, that is the right coronary artery, it will supply blood to the inferior wall of the left ventricular, the right ventricle, and the SA node in 55% of the patient, and AV node into in 90% of the patient. So it supplies QV, Q waves, and ST segment elevation. The evaluation of for right ventricular wall involvement has to be checked. The hemodynamic changes are to be checked, and the potential for significant arrhythmias, which are because of the SA node and AV node dysfunctions. And lastly, right ventricular wall, right coronary arteries are involved. It supplies blood to the inferior wall of the left ventricular, the right ventricle, and the SA node in 55%, and AV node in the 90% of the people. There will be Q segment and ST segment elevation in the right precordial chest slits, and evaluation for inferior wall involvement has to be checked. Some hemodynamic changes, potential for significant dysrhythmias because of SA node and AV node dysfunction. Now you can see that wherever these are common, example inferior wall and right ventricular, they have common pathways. So when inferior wall is involved, we have tried to check right ventricular wall involvement also. Wherever there is right ventricular wall, we have checked for evaluation of inferior wall. Same is when lateral wall, there we have tried to check posterior wall, because lateral and posterior the blood supply is similar, that is left circumflex, and in inferior wall and right ventricular it is same artery, that is right coronary artery. So it can be both, it can be common, and therefore maximum area has to be checked. Wherever the blood supply is there, wherever these arteries are supplying blood, that areas are there. So these are various important areas, or we can say location wise classification of myocardial infarction. And we have also seen that what are the ECG changes are occurring during that. Now let us how we will assess, or what are the etiological changes we can get. The patient with MI, they describe heaviness, squeezing, choking, or smothering sensation in chest. They often describe that someone is sitting on my chest, or someone is pressing the chest heavily. Substantial pain can radiate to neck, left and back and jaw. That yesterday we have seen, I told you earlier also, similar to that of angina. Unlike the pain of angina, the pain of MI is more prolonged, and it is unrelieved by rest or sublingual nitroglycerin. This is a very important difference, because angina pain is because of the vasoconstriction, and it can be taken care of, or there is only demand supply problem. Here it is not there. It is here demand may not be increased. Supply was going normally, but all of a sudden there is a blockage, there is obstruction. The associated findings on the history includes nausea, vomiting, especially for the patients having inferior wall MI. These gastrointestinal complaints are believed to be related to the severity of the pain and resulting the vagal stimulation. So these are responsible for pain. Now what we have to do, what physical examination, patient appears restless, distressed, skin is warm and moist, breathing can be labored rapid, Crackles can be there in the breathing. Fine crackle, coarse crackle, or ronchi may be heard when the osculating the lungs. So these are various sound types like fine crackles, like crackling sound like that. Coarse means slightly, fine are very fine, they are minute. Coarse are somewhat better or loud, and ronchi means again one more uh, different type of sound which can be heard when auscultating or whenever we put stethoscope there. There is increase in the blood pressure related to anxiety or decreased blood pressure which is caused by heart failure. The heart rate may vary from bradycardia to tachycardia. On auscultation, the first out sound may be diminished because of the decrease in the contractility. Fourth sound, if you remember lub dub, again, the fourth out sound is heard and almost in patient with MI, whereas third sound is detected only in 10 to 20% of the patient. There is a transient systolic murmur can be heard after 48 to 72 hours. Many patients acquire a pericardial friction rub, that is that they can sense that something is getting friction or getting what we can say rubbed with that. Patients with the right ventricular infarct may present with the jugular vein distension, peripheral edema, and elevated central venous pressure. Now, various diagnostic tests I told you, again we will discuss. First is, and very important, is ECG. Immediately ECG is conducted and simultaneously it can be done. So this type of thing is known as a ST elevation. See, if you know the normal curve, you will find that this is P, Q, R, and then S, and then T. So here from S to T, these are not there. The S has gone here. In first case, you can see that S has elevated. So this is called as a various ECGs. So these are showing various ECG changes, and this will lead to, or this will give diagnosis, that is there is a ST elevation, and here is a T wave inversion, the third graph and the fourth graph, that will show the T wave inversion. And S is elevated but T is inverted. So these are very typical graphs which are showing, which are the indicative of myocardial infarction. When the myocardial injury persists, MI is the result. During the earliest stage of the myocardial infarction, that is called as a hyperacute phase, the T wave becomes tall and narrow, and it is referred to as a hyperacute or peak T wave. Within few hours, these T waves are inverted, and I told you inversion of next ST segment are elevated. The pattern usually lasts from several hours to several days. And in addition to ST segment elevation, the leads to ECG facing the injured heart, the leads facing away from the injured area may show ST segment depression. So this is known as a reciprocal ST segment changes, and they are very, very important diagnostic tools and very easy actually. So these are various ECG solution, ECG changes. The last stage in the ECG evolution is the development of Q waves. Initial downward reflection of the QRS complex. Q waves represent the flow of electrical forces toward the septum. Small narrow Q wave may be seen in the normal ECG in lead 1, lead 2, lead 3, then AVR lead, AVL lead, V5 and V6 leads. These are different leads. There are 6 leads or 12 lead ECGs are there. Whatsoever ECG you might have seen in earlier year, that is anatomy, physiology or cardiac cycle and ECG you have seen, that is called as a three electrode one, okay. But the better one, they are coming, there are multi-lead are there, and there are multiple leads are put into, 6 leads or 12 leads are there, and accordingly you get different kind of ECGs. Very prominent, very easy to understand is type 2, which you have studied earlier, okay. Or whenever we say PQRS complex, usually we refer the type 2 type of ECG. So here this is the ECG which is there, which is taken. Q waves compatible with an MI are usually 0.04 second, and they are more in the width or 1/4 to the 1/3 of the height of the R wave. Now here one small box means the ECG graph are there in that, just like a graph paper you might have seen. So these are small and big boxes are there. So this small box is there, that is it is for 0.04 second, and that means it indicates that it is 0.04 second. Q waves are indicative of infarction. They are usually developing within several hours of the onset of infarction, and but in some patient it may not appear until 24 to 48 hours after the infarction. So these are various changes in ECG. One few more are there, like within few days after MI, the elevated ST segment return to baseline. Persistent elevation of ST segment may indicate the presence of ventricular aneurysm. Aneurysm, whether anybody knows, aneurysm is the condition where, I think earlier somewhere we discussed it, but I'll repeat. Aneurysm is the case where aneurysm means so if somebody has seen tire which has been cut from outside and the tube is coming out, okay, because pressure is there, and because of the air pressure, because of the rupture of tire, it is coming out, and it can burst at any time. So this type of thing is known as an aneurysm. That means there is a decrease in the thickness of that particular segment. So it can be, if it is ventricular, then that ventricle which was having thick mass of muscles and various tissues, here it will be reduced. Most of the mass has been now damaged, destroyed, and it has removed. So if it is aneurysm is there, that means it has become less mass. If it is less mass, then if the pressure comes too much, then it can burst at any time. This is called as a ventricular aneurysm. Okay. Similarly, it can be an arterial aneurysms can be there, which are reasons for various hemorrhages. That because of this aneurysm, this part of the tissue or this particular thing, their thickness is reduced, and because of the reduction in the thickness, with higher pressure, this can cause bursting of that or rupture of that, and if it is a rupture, then whole blood can come out of it. It will cause hemorrhage. The T wave may remain inverted for several weeks, and it indicates the area of ischemia near the infarct region. Eventually, the T waves should return to their upright configuration, and the Q waves do not disappear, and therefore always provide evidence of previous MI. So Q wave are indicative that the person has got myocardial infarction once or while. So these are various Q waves. See, if you can see P, Q, Q is fall like that, R is, and S and T are there. You can see these are the pathological changes which can see, and there are having greater than where Q is having greater depth than 3 mm or greater than 1/3 of the height of R wave. So that indicates, okay. So this is total from this. If it is height of R wave, then it is the indicative of the permanent necrosis or damage. For right ventricular correct view, the right side chest leads are recorded by blasting 6 chest. I told you there are various leads, and they are electrode on the right side of the chest. They using landmark analogous to those of using left side. Nowadays, therefore, we get 12 leads. So 6 on left side, 6 on right side, like that. And they detect posterior wall abnormalities. 3 type of precordial electrodes are placed posteriorly over the heart, and that is known as a V7, V8 and V9. These are various positions of the electrodes, and accordingly different ECGs are obtained. V7 is positioned at the posterior axillary line, V8 at the posterior scapular line, and V9 at the left border of spine, and then from that various graphs are there. Then another diagnostic tools, I told you biomarkers. The first one is creatinine kinase, I told you as a homework, please go through, please see that what kind of biomarkers are available. So creatine kinase, there are a variety of creatine kinase. One is creatine kinase M, which is present in muscle. This is MB, which is present in specifically heart muscle. And since during even other muscular injury, CK can increase. So usually it is supposed or it is expected or it is guided that you should take ratio of CKMB to CKM. So when this ratio increases, when CKMB comparatively increases too much, then it shows sign of that. It appears in serum within 6 to 12 hours, it peaks between 12 to 28 hours, and then it will return to normal levels within 72 to 96 hours. And therefore various samplings are done after 4 to 6 hours in first 24 to 48 hours to verify it. Then another is myoglobin. It can be elevated within 1 to 2 hours of the acute myocardial infarction, and it peaks within 3 to 15 hours. Then troponin, I told you troponin, that is troponin T, and one more is troponin I. There are varieties, and they'll increases within 3 hours, peak at 14 to 18 hours, and it will remain elevated for 5 to 7 days. And troponin T also, it increases within 3 to 5 hours, and it will remain elevated for 10 to 14 days. So this type of graph is there. These are various markers at what time they increases. This is also, as I told you can check or you can go through Hirschsprung. So these are the levels and time days after the onset of acute myocardial infarction. So CKMB will immediately go down. Okay, if somebody goes for the next day, then there is no use of it. So what's your normal range is there. Okay, what will changes will takes place. So in few hours you will find that CKMB increase, and within 1 day it came back to the normal. Then the creatinine kinase, again it takes 2 to 3 days to come to normal. Troponin T, we have seen that it takes several days, 7 days to 14 days. And LDH is again in the same way it is working. Hello. बस संपता नाही. बरं. हां 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 बरं. बरं बरं ओके चालते. मग 4ला माझं परत सुरू होईल दुसरं. मग सर त्यांनाच विचारून काय करायचं. ठीक आहे चालेल. So these are various markers, and they are very very important tool for myocardial infarction. So let us see, we'll go for this in next class, that is how to management, what care we have to take, what are the drugs which are used. This is what the management of myocardial infarction. So we'll go for this in our next